So thank you. Would like to take you, forward from the last slide only. May the divine, protect the womb and make the child healthy. And first of all, by thanking the organizing committee of Diabetica 2025, would love to move ahead and taking you through how this particular phase, gestational diabetes mellitus, can be a window of opportunity for the prevention of non-communicable diseases. Because when it comes to gestational diabetes, it's not only one disorder. It is a constellation of many other things, many other conditions. Many things comes into a mind of a clinician when he or she is dealing with a person with or a lady with gestational diabetes mellitus, and that's why gestational diabetes mellitus is not just a hyperglycemic disorder. It's a metabolic and reproductive disorder. We all know that our pancreatic beta cells secretes the insulin, but does this secretion of insulin is the same when it is a normal healthy adult, when it's a pregnant mother without gestational diabetes, when it's a pregnant mother with gestational diabetes? No, it differs a lot, because of placental hormones and many other hormones and the movement of nutrients across the placenta. The difference is very differs when it comes to a normal healthy pregnancy or a lady with gestational diabetes. We all know that glucose transfers smoothly, but not the insulin, and this leads to the things whenever there is a hyperglucose or hyperglycemia. This hyperglycemia stimulates the beta cells. It leads to more insulin. Insulin targets the maternal tissues, and again, it results in insulin resistance, which moreover, because of placental hormone, it increases more insulin resistance. Ultimately, overall glucose loads comes on the fetal pancreas, and fetal pancreas has to be more overstimulated. More insulin secretion from the fetal pancreas can lead to fetal macrosomia, and it doesn't, the story doesn't ends here. There are many other biochemical reactions which takes place, not starting from the intrauterine, but also the epigenetic environment sets on, and it can lead to DNA methylation or histone modification or non-coding RNAs, and this all sets the theory where a fetus of a lady with gestational diabetes into the intrauterine only has develops a higher risk for developing of cardiometabolic disorders. Either you take as a NAFLD or as a diabetes or future cardiovascular risk, and this all sets in utero, and that's the reason nowadays. We all have learned during our MBBS that we are taking care during pregnancy, first trimester, second trimester, and third trimester. Nowadays, we need to be alert, and nowadays this postpartum period, we must call it as a fourth trimester of pregnancy, and we all should act upon that, even not only the first trimester. But yes, my concern today is to act on the first trimester so that we can prevent all this cascade. And this is not the new. This is all the way defined with our ancestors. Even this is the, I must say, this is a slide from our own Dr. Salini Jaggi and Rajiv Chawla, sir. You have been across through this slide. This is a Garbh Upanishad, and that says that unborn baby in the womb of his mother, 5 things are fixed, and that is his lifespan, activities, acquisition of knowledge, wealth, and his time of death. In the same way, intrauterine environment decides not only intrauterine malformation, of course it's a hypothalamic malfunction, also obesity, delayed neurocognitive development, neuropsychiatric disorder, neurodepressive degenerative disorder. And so it's not only the things about hyperglycemia, and that's what the conceptualized theory of David Barker's, the theory of intrauterine programming of the fetus. So what is this exact the fetal origin of disease hypothesis? That During the initial first trimester, that's a period of organogenesis, we all know, and this is a critical period during which metabolic and physiological functions of the adult lives are decided, and adverse environment in the fetal life, it decides the early childhood and make a person, make a fetus at the increased risk of developing some disorders in earlier life. So it's the intrauterine environment plus phenotypes plus epigenetics that decides what will be there into the future, and this is what we call as a intrauterine programming, and that decides the future of the fetus. And that's why we all know that, in Gujarati it says barako loi pinaro. It's like, fetus is always depending on the mother. It is continuously seeking the nutrition. Maternal mother is intermittently eating the host, and this maternal metabolism in pregnancy changes the physiologically to provide the uninterrupted nutrient supply to the growth of the fetus, and that leads to fetal insulin hypothesis, and this ultimately forms the base of the theory for the Patterson's hypothesis, where maternal hyperglycemia ultimately will lead to macrosomia, organomegaly, or hypoglycemia. Now, along with that, the Franklin hypothesis, which states that it's not only the glucose, it's a fuel mediated teratogenesis. So that's why, we have to be, and again, if you see the advice from our ancestor, even taking care of the mother who is pregnant starting from the day one, because I think that was into their mind, into their ancient science, even how this fuel mediated teratogenesis can affect the future of the fetus, and that again forms the base of the Franklin hypothesis, and that is what we are now talking as a modified Franklin and Patterson hypothesis, where pregnant diabetes or hyperglycemia in pregnancy can ultimately decide the future of a fetus in the terms of development of metabolic disorder, either glycemic intolerance or gestational diabetes or other cardiometabolic diseases. So women with the history of GDM are at the increased risk of future diabetes, predominantly type 2 diabetes as their children, and this can ultimately lead to altered physiological functions like insulin resistance or beta cell dysfunction, and put the person, not only the mother as well as the fetus, at the higher risk of developing cardiovascular disorder. And that's the reason, this is forms again the base of this developmental origin of health and disease, which, as I had discussed earlier also, that few biochemical alteration like DNA methylation and mRNA that plays a crucial role, and that's the reason, we have to be crucial during this initial phase of gestational diabetes mellitus, and because this this will form again the future of a baby, and that's why I think, we all are now agree upon this statement that at least we must have a universal screening and prompt management for all our pregnant women for the glucose tolerance, because it's not the individual priority, it's now the public health priority. So prevention of diabetes, preventive measures against the type 2 diabetes does not start in adulthood. It should start intrauterine only and continue throughout the early childhood. And in that way we can say that the female gender or the GDM provides an opportunity, a window of opportunity, to stop the development of non-communicable disease, because if we are able to target this low birth weight or large weight for gestational age, and if we can stop the progression, it may not lead to again obesity and hypertension. So it is the stage intrauterine where we need to act upon to prevent the bad future of the person, and that's why GDM, early screening and management, all the things are there, and that's the only reason we are saying that. And yes, when Sunil Gupta sir is there, GDM, of course, it's a window of opportunity. I think nowadays it should be called, it's a door of opportunity. Let's knock it and let's hit it hard and let's target it so that we can prevent our future generation from developing. This is a beautiful article, just recently in 2025, after the 60 years of O'Sullivan and Mahan. regarding gestational diabetes development, and they also emphasize upon this vicious cycle of gestational diabetes, where if we are able to stop the progression of gestational diabetes, I think we can think the future where we can have a healthy generation. These are the recommendation given by FIGO for the prevention of gestational diabetes to halt at earlier, so that we can have a healthier future. And to conclude, would just love to say these words from our, Dr. Sesia sir's one of the presentation, which I think I have heard from Dr. Chawla sir and Gupta sir also, that we are as a clinician have been offered this rare opportunity to alter the natural course of the disease and change the future of health of the woman and that offspring. So, it is in our hand where we can again act upon. We can not only save or make the life beautiful of a lady with gestational diabetes, but also we can, predict or make a good life of next generation even. And that's why GDM is truly considered as a window of opportunity for the prevention of non-communicable disease. Again, as usual with Honorable Dr. Sesia sirs, let's say that if we want to think the future of diabetes-free generation, let us focus on the fetus for the future. With this, thank you all. Thanks a lot.